Greetings. First of all, I would like to thank Dr. Akvi Asombank and Dr. Ganiat Oileki for their kind invitation to present this talk at the Lagos University Teaching Hospital Training Center program in Nigeria. The title of my talk is Electrosurgery in Gastroenterology. It is more than the blue and yellow pedal. And these are my acknowledgements. And my objectives today include the following. What is it that we could tell our patients when we counsel them about electrosurgery? As a nurse, what preparation is undertaken for the procedure? Review the electrosurgery basic principles and how do we set up the electrosurgery unit and operate it. And lastly, a little bit about my settings for resection. So, when you see a patient with a large polyp, you could share that we have a very long track record in electrosurgery, with the first description from Dr. Shinya in the New England Journal of Medicine way back in the 1970s, documenting the feasibility as well as safety of large polyp removal without the need for surgery. In the last 40 to 50 years, electrosurgery has certainly evolved. With electrosurgery, we are able to remove or resect large polyps using a combination of cut and coagulation currents. We could also control the bleeding, otherwise known as hemostasis, using coagulation current. And recently, we have also been using the coagulation current to decrease the recurrence of polyp by ablating the edge. Let me share with you some important principles in electrosurgery. What is it that the patient should do? When it comes to colon polyp removal, the patient should be educated about cleaning their colon so that when you do the procedure, we have a good outcome. When you perform electrosurgery in a dirty colon filled with methane gas, there is a possibility of explosion of the colon, which can be life-threatening. If a perforation were to happen during polypectomy in a dirty colon, that could potentially lead to fecal peritonitis and a need for a colostomy. So it is very important to have a clean colon for endoscopic electrosurgical removal of colon polyps. Now coming to the pre-op preparation, there are a few things that every nurse should do when a patient comes in for polyp resection. The nurse should ascertain that the colon preparation has been excellent, asking the patient whether the effluent was clear and they were able to see the bottom of the toilet without any residue in the bottom of the toilet. They should ask them about any implants, including devices such as pacemakers and defibrillators. If we have to deal with those, it is important to plan the procedure early in the morning if in case that device needs to be checked by a cardiologist. If you don't plan it right and you end up doing a procedure late in the evening, you may be stuck with taking care of that patient and worrying about how to reset the defibrillator and pacemaker. It's also important to tell the patients to come to the procedure without any jewelry. And if they come in, you need to make sure that they remove all the jewelry as well as hearing aids, as these devices could conduct the current and lead to local injuries. If a ring cannot be removed, the nurse should take precautions to tape the ring and insulate that ring from the skin contact. Now let us look at electrosurgery, some basic principles. You can see a lot of devices operate across a wide spectrum of electromagnetic spectrum. And when it comes to electrosurgery, we should stay certainly above 100 kilohertz, because that's when one could get electrocuted. So the typical settings used for electrosurgery are in the 3 to 500 kilohertz range. Coming to the electrosurgical circuit, the current is generated by a generator, and the electrical current flows through the snare to the tissue of interest, and from there to the patient's body and back to the generator using a dispersive pad. This is important for any monopolar electrical circuit device. What happens when you use this type of circuit? What happens is the current goes through from the generator to the snare to the tissue of interest, and then the local temperature increases to above 100 degrees if you're planning to cut, and that intense heat is the one that delivers the desired effect. And at this point, I would like to introduce a concept that is important for all of us to keep in mind, that is current density. So take, for example, a pedunculated polyp, and you put the snare around the stalk of the polyp and you squeeze it, and wherever you squeeze it, that's where the current density is the maximum, and that's where you get the maximum heat, and that's where you will see the cut. But it's also important to appreciate that although that's where you see the cut, there is a lot more damage that may be visible or not visible to your eye. So this is a concept I want you to keep in mind, so that when you're removing a polyp, especially a pedunculated polyp, try to use your snare on the stalk away from the wall, so that if it requires a lot of time for application, then the chances of deeper injury will be less. Now, let me introduce you two concepts that are used in electrosurgery: cut versus coagulation. This is dependent upon the voltage that drives through the tissue. And let us first look at coagulation. Coagulation is typically done when you keep the voltage below 200 volts, and that results in a slow, simmering heat that results in cellular dehydration and soft coagulation. The same effect could also be achieved by a higher voltage when you interrupt the cycles with a 6% duty cycle or a little bit higher. We will talk about it in a couple of seconds. In contrast to below 200 volts, peak volts, if you increase it to above that, it results in rapid heat generation to the point of boiling that results in cellular vaporization and disruption of the cellular membranes very quickly, and eventually a pure cut results. So these are the two basic principles for cut and coagulation: rapid generation of heat or a slow simmering heat, cellular vaporization or cellular dehydration. So let us look at it in a different way. Here is a duty cycle less than 200 volts, peak volts, results in soft coagulation. You can see this is used for hemostasis as well as for ablation of the edges, if you want to ablate the edges after resection of a large polyp. On the other hand, if you increase the voltage to above 200, it results in a cut. If you create interruptions in the cycles, either a 50% duty cycle or a 6% duty cycle, depending upon how long you interrupt, during that interruption, the tissue cools down and that slow heat results in more coagulation. So we've learned about peak voltage, cut, coagulation, soft coagulation, and also learned a little bit of duty cycle. Although there are a number of factors that impact the tissue effect when you're applying a snare, there is one thing that is very important in terms of the extent of damage, and that is the total duration of application of the electrosurgical current. If you apply a snare around the stalk of a polyp or a large sessile polyp and it takes a longer time, you should be worried in the colon for a potential delayed perforation, because although you may not see perforation immediately, there is going to be, as we have seen, a lot of damage that you may not have appreciated that would eventually lead to necrosis a few days later and delayed post-polypectomy syndrome and perforation. So I would like you to keep this thing in mind, and when you try to cut, I try to squeeze my snare as tight as possible and try to apply as minimum duration of current as possible so that I have clean cuts with less damage going deep into the wall. Now let us look at how do we operate in the endoscopy room using electrosurgery. So here is a patient with a large polyp. We decide to remove it with electrosurgery, and you have the electrosurgery unit in front of you, and let us learn a little more about the electrosurgery unit. You have a control section and a circuit section, and when it comes to setting up for electrosurgery, the nurse starts with applying the dispersive pad, and let us learn how do you best apply a dispersive pad. It is typically applied in the loin where you have a lot of muscle that is closest to the site of electrosurgery, and typically applied over a large fleshy area or a muscle mass. Avoid putting it on a bony surface, and also avoid tattoos, avoid hairy areas, and also avoid and stay away from electrical devices or any metal. So these are the principles to keep in mind when you apply the dispersive pad. And then you take the electrode and plug it into the neutral socket, and then to the monopolar socket you plug in another electrode that goes to the snare. So now you turn the machine on. So you press the power button to start the machine, and I heard that you will be practicing on OB machines. So if you this is a little bit of an older generation. If you have this machine, you will learn how to use this, but the principles are the same. Once you press the power button, most of these machines are preset. You select the program, and then on the right side, you will see the pedal icon light up, and you press on that to engage the program, and then the program that you selected will be set. So now you're ready to go ahead and do the resection of that large pedunculated polyp. When it comes to resection of a large, thick, stalked polyp, I would like to share with you what you should do to prepare your snare. You should pick up the right size snare, depending upon the size of the head, maybe 15 millimeters, 20, 25 millimeters, and take a marking pen and slightly open, keep your finger and the thumb ring and the forefinger and the middle finger in the slider, and slightly open your hand till the snare metal tip comes to the end of that plastic catheter. And once you notice that, you mark the position of the slider on the slider, and I'll tell you why we should do this. So here is a polyp. It has a maybe 5 millimeter stalk, and you are lucky to get your snare nicely around the stalk in the first go, and then you check on the slider and you estimate that the stalk is 5 millimeters, and on the slider it looks good. That means you got the snare around the stalk without trapping any other tissue. On the other hand, you see that you think it is 5 millimeters, but the slider has gone too far out. That means you probably trapped additional mucosa. This particularly happens around a bend. So in that case, you may have to reopen the snare and make sure that you are able to just encircle the stalk. So this is very important for somebody who's starting, so as to avoid causing additional injury to the surrounding tissue. So once you are ready to go, as you can see, electrosurgery, it is very important to have your electrosurgery unit right in front of your eyes. And here the endoscopist is asking the nurse, could I see the settings? And the nurse brings it in front of the team, and one should be able to see the settings. And depending upon what the endoscopist wants to do, some endoscopists do the endocut setting that is there, or some use the forced coagulation. So when it comes to activation of the electrosurgery unit, you press on the foot pedal, and if you press on the yellow pedal, it leads to cut, and if you press on the blue pedal, it leads to coag. So yellow for cut and blue for coagulation. So as you can see on this monitor, on the left side is yellow, painted yellow, on the right side a blue. So left side is cut and right side is coag. So, but unfortunately you tried to cut, but nothing worked. And in that case, what you should do is you should check the circuit. And you would know when you look at the neutral electrode and you see those two orange foot pedal color, that means the circuit is not right. You may have to recheck the whole circuit, whether everything is plugged in right. And sometimes the assistant forgets to plug in the electrode into the snare handle. So that's all been checked, and now it looks that the circuit is complete, and we should be able to go ahead and cut that polyp. When it comes to cutting the polyp, you should understand what these three things mean: effect, duration, interval. Let us learn about effect. There are 4 settings for effect. Setting 1, that means there is no coagulation in between those red bars that indicate cut. Setting 2, effect 2 gives a soft coagulation in between the cuts. Effect 3, that is setting 3, delivers a forced coagulation in between cuts. We usually, in endoscopic surgery, we go up to effect 3. We don't go up to 4. But if you use 4, you'll have more coagulation. So let us see what it would look like with these different settings. So with setting 1, you have no coagulation. It's almost like a pure cut. With setting 4, there's quite a bit of coagulation in addition to the cut. Now let us look at duration. Duration is the duration of the cut. With setting 1, you'll have a very short cut, and with setting 4, when you press on that yellow pedal, you have a longer duration cut. So I typically keep my settings at 1 because I could control the cut with short bursts. If I use a longer burst, you may have a longer cut. Sometimes I use a cutting duration of 2 or 3 if I'm dealing with a lot of fibrosis, and we will talk about it later. Now coming to cut interval. This is the interval between the cuts. As you can see, setting 1 has 400 milliseconds. We typically use 313, that is 720 milliseconds. You can increase the cut interval if you want to give more coagulation in between to 5 or 6 when you're dealing with a thick pedunculated polyp. So we learned about endocut cue, effect, duration, interval. Now let's look at forced coagulation. Forced coagulation is typically used for removing pedunculated polyps, and at this point I would like you to appreciate a couple of other terms. We learned about soft coagulation, where the peak voltage is less than 200, slightly higher voltage for force, and much higher for swift coagulation. In colon polypectomy, we either settle between soft coagulation for hemostasis or ablation of the edge, forced coagulation for removal of thick pedunculated polyps. So let me share with you what do I do, what settings do I use, and my EMR settings typically are endocut Q313, and I rarely change them. But recently what I've done is I moved my forced coagulation to soft coagulation setting so that if I cut and I end up with some bleeding, I'm not in the middle of asking my assistant to change from forced to soft coagulation. So I don't want to waste the time. So instead, I've set these parameters. So if there was bleeding, I could just tap on the blue pedal and deliver the soft coagulation. For thick pedunculated polyps, I typically use forced coagulation. When it comes to removing thick pedunculated polyps, these polyps tend to have multiple feeding vessels, and it is best to observe the head of the polyp. If the head of the polyp looks smooth and not retracted, not ulcerated, and the chances of malignancy is low, I typically place my snare a few millimeters below the head on the stalk and a few millimeters away from the wall. And if in case the stalk is too short, I may inject and create a pseudo stock before I apply my snare. And in a sigmoid colon with a large polyp, when the polyp head is touching the opposite wall, if it touches a focal point and that becomes the area of contact, or that becomes the area of highest current density as the circuit is being finished, you could have a counter burn. So when you have a large thick pedunculated polyp and you want to remove it, it's a good idea to gently shake your snare so that there is a larger contact and there's no one point of contact when you're applying your coagulation current. Sometimes I use water immersion so that to see if I can float that polyp away from the other wall, and those are the things that I try to do. So having a broader contact allows you to have a safer cut without counter wall injury. It's also a good idea not to squeeze the polyp and apply a lot of traction, because then your current density moves from the snare to the narrowest portion, and you may end up with a big bleed. Also, keep in mind, if there was a clip in that area, there could be transmission of electricity to the clip and a counter burn. When it comes to large sessile polyps or flat lesions, and in the cecum, I typically inject fluid to lift the polyp away from the wall. I typically use saline with a little bit of indigo carmine or methylene blue, and then do the resection, and this tends to limit deeper thermal injury. So we covered a lot of topics, and I would like to share with you. You could also listen to a detailed presentation of this talk on Zoom class 11 that we did last year. And those of you who want to learn a little more about how to resect different types of polyps, I have uploaded several videos to my YouTube channel over the last 10 years, and I hope you find them useful. And I would like to bring best wishes from Houston and my institution. And again, I want to thank the organizers for their kind invitation. Thank you.